I do quite a lot of surgery aimed at people's watery eye or tearing, which is known as epiphora. So these are patients who have watery, perhaps sticky eyes, which until you've had a watery eye doesn't really sound much of a big deal. But in fact, it's a very big problem for patients, particularly when they try to read, because the water wells up in their eyes, and when they look down to look at something, they're basically looking through a swimming pool. I think there's a general perception that, oh, well, there's nothing much to worry about. But until you've had it, you don't realize how annoying it is. And so there are lots and lots of different causes and treatments for watery eye, and it needs a thorough investigation and a management plan. And it can range from the minimalist intervention of just cleaning up the eyelids, treating underlying blepharitis and lid hygiene issues, to quite significant major surgery that can take up to an hour to do. So there's a broad suite of different problems that are encompassed by watery eye, and it can range from newborn babies to 95-year-olds. It's a big field. So at the end of the day, a watery eye is not going to kill you. You're not going to drown, but it's a lifestyle problem. There are also certain reasons why you would definitely want to intervene. Firstly, if patients were getting recurrent infections in the tear sac, so-called dacryocystitis. So if you're getting infections on a monthly basis, then I would say, that's got to be dealt with. Secondly, if you've got a sticky, watery eye and you have a cataract, nobody's really going to want to do your cataract until the sticky eye is dealt with, because the stickiness is a risk for infection, and infection is what we dread most in cataract surgery. So until the risk of infection is taken away, you're not going to get your cataract done. So there are patients who aren't terribly bothered by their watery eye or prepared to live with it, but they're heading towards cataract surgery. And in those few instances, I would probably push them towards surgery rather than leaving it up to them to decide, because you know that in 2 or 3 years' time, when the cataract needs to be done, and they may be that little bit older and less fit for anesthesia, they might be patients that should really get it out of the way while they can, rather than leaving it until a point where they may not be fit for surgery, particularly if they're elderly. But by and large, those are the two reasons to intervene: either symptoms, lifestyle, inability to read, socially embarrassment from looking as though you're crying the whole time, and then the chronic sticky eye that keeps getting infected, or a sticky infected eye that might be heading towards cataract surgery. Those are the sort of 3 main indications in my mind. Also, all surgery carries risk, I'm not going to deny. The surgery is usually, well, it depends on the type of surgery, but the tear duct surgery is usually done under general anaesthetic, so there's the anaesthetic risks involved with that. Alongside that, there may be issues around blood thinners and whether or not to stop those, which carries its own sort of sets of risks and benefits. In terms of the actual surgery itself, there's about a 95 plus 19 out of 20 success rate, which of course means there's about a 1 in 20 failure rate. So that, I suppose, is the biggest risk in terms of statistics. In terms of medical risk, the main risk we worry about is bleeding, because it's nasal surgery. So it's, how much your nose bleeds if you get a nosebleed. So that's the kind of thing we want to avoid with surgery. There are small risks associated with the surgery where you can get problems with the CSF, which is the fluid that bathes the brain, leaking. I've never seen or had that. All in all, I think it's a very safe surgery, and the main risks really are around anesthesia and being fit for the surgery. Surprisingly not, actually. I don't routinely prescribe painkillers after lacrimal surgery. So once the surgery is finished, patients, or in my practice, will have a patch over their eye, which is removed in the morning. That's primarily to reduce the bruising and swelling. Patients go home with eye drops and nasal inhalers. I used to give antibiotics, but I don't anymore. And I don't routinely prescribe painkillers. nothing more than paracetamol or Tylenol would be indicated, really. So after a DCR surgery, which is the tear duct surgery, I recommend patients don't sort of bend down or lift anything heavy. I don't make themselves red in the face because of the risk of bleeding for about a week. And I ask them not to blow their nose for 2 weeks. And the bruising's usually gone by a week to 2 weeks, and the little stents, the little tubes that are left in the tear duct system to stop it scarring shut again, are removed at about 6 weeks time in the outpatient clinic. And basically I snip the tubes and ask the patients to blow them out, as in when they blow their nose. So recovery in general terms is perhaps a couple of weeks. You might want a week off work. The incision tends to heal up very well. There are papers that suggest about 1 in 20 people notice the incision after surgery, but it's not a common problem. Particularly patients of that age tend to wear glasses anyway, and the incision sits just under here.